Hey guys, let's talk about cancer in general. I know this week is not very exciting, so we'll try to be as simple and clarify as much as possible on what you're really needing to know in general to take care of the patients. So the patient with cancer, so cancer is a really broad topic. So cancer is just uncontrolled, unregulated growth of cells. So it can, the cells are regrowing in a discombobulated fashion. Two major dysfunctions in the process: a defect in cell proliferation, a defect in cell differentiation. So if you're looking at the development of cancer, so if you look at this, for example, the cell that is constantly attacked with viruses or hormone irregulation, or there's radiation or some kind of chemical damage, or genetic factors. So I know, remember when you heard from the breast cancer patient, they looked at some genetic factors. So a genetic predisposition could indicate that certain cells will be continue to mutate. So then the cell becomes altered. Then there becomes dysfunction and differentiation and proliferation. So essentially, if there's any replication, you're replicating a altered cell, or the body is unable to differentiate the cells from normal, versus, because remember, if the body's constantly on surveillance with immunity, so if the body is seeking out cells that are bad, essentially, the body should attack it. But in the cancer, the immunity is unable to differentiate those cells from normal cells. So then cancer cells develop. The promotion, second stage. So this characterized by reversible proliferation of the altered cell. But now there's the progression, the increased growth rate of the tumor, increased invasiveness, metastasis, and this depends on what stage the cancer is. So we spoke about the immune system. So the immune response is to reject or destroy cancer cells. If there's no differentiation, then the immune system cannot do that. Some cancer cells have changes on their surface antigens, so they're called tumor-associated antigens. And then the immunological surveillance is what I was talking about. These are the body's way to hopefully get rid of the mutated cells. So you have what you need to know, there are two types of cancers, or there are two types of neoplasms. Oh, that's spelled wrong. It's neoplasms, not neoplams. I don't know if that autocorrected. So you have benign and you have malignant. Encapsulated means that the neoplasm doesn't spread outside of the particular area. You heard that word back when we were talking about Pott's disease and tuberculosis. And like the tuberculosis was encapsulated, so it's not throughout the body. So benign neoplasms are usually encapsulated. They are rarely encapsulated in malignant. So malignant tend to go outside of the borders. You can think about it that way. They're not staying in their neighborhood. Differentiated, so that's specifically with the cells, and that's, for example, skin cells should look like skin cells. Liver cells should look like liver cells. So differentiated means if, for example, the neoplasms, if they're malignant, well, the liver cells aren't looking like liver cells anymore, for example, in liver cancer. This is, pardon me if I'm dumbing it down too much, but it's an easy way to think about that. Metastasis, so benign, they don't really travel, okay? But malignant, they can travel. So that's what the metastasis means: travel to other organs, travel to other parts of the body. Benign, rare recurrence, and malignant, it is possible for recurrence. Now, when one says that they're in remission, that means that their cancer has halted, but it could possibly recur. Vascularity tends to, like, how, so think about if the blood is what makes things travel, makes oxygen, makes or brings oxygen to all parts of the body. So the blood is the transportation system, right? So with malignant, moderate to marked means that that neoplasm, that tumor, has a lot of vascularity. So thinking about it plumbing wise or transportation wise, that is why metastasis is capable. Mode of growth for benign, expansive, that just means how large it can be. Malignant is infiltrative and expansive, so it infiltrates other parts of the body. This would be with metastasis as well. Then the cell characteristics, that kind of goes along with the differentiation. So the benign, fairly normal, similar to the parent cells, but in the malignant, the cells are, like I said, they no longer looks like liver cells, no longer looks like lung cell tissues. So classification of cancer: anatomical site, histologic, clinical staging, and TNM classification system. So in general, what you want to know is the higher the grade, the worse it is. The higher the stage, the worse it is. TNM has to do with that specific cancer and that classification. It doesn't necessarily have to do with like you would not be able to substitute TNM classification system with clinical staging. So they'll classify, they will stage them and put them in a particular classification system. All right, let's see. All right, so the 7 warning signs of cancer. So this is part of your history and your subjective information you're getting from the patient. You're asking them about their bowel or bladder habits, a sore that does not heal, unusual bleeding or discharge, thickening or a lump in the breast, ingestion or difficulty swallowing, obvious changes in wart or mole, nagging cough or hoarseness, and pretty much something that just doesn't go away. Again, key is prevention, right, and early detection. So this is in moderation: limit alcohol intake, participate in regular exercise. These are actually all things that one should do with any system. But your education for prevention and early detection of cancer includes practicing self-examination, teaching testicular self-examinations, teaching breast self-examinations with the patient. And the key is also when the patient, there's more success when the patient really knows what their body looks like, how their body is, how their bowel bowel regimens are, their bladder regimens. Your diagnostic studies for cancer include cytology studies, tissue biopsy. Now your chest x-ray just looks at the lungs, looks at the bones, so that would be diagnostic for metastasis, etc. Like I know our guest speaker, her cancer went into her rib cage. Your CBC, that looks at your lymphocytes, right? Looks at your blood panel. Your chemistry profile, if there are imbalances in your electrolytes, your kidneys. Liver function studies, endoscopic exams. So those would physically look at those particular areas. The upper GI would look at the esophagus and the stomach. Your sigmoidoscopy, colonoscopy is looking at the colon. And here are some of the other diagnostic studies. Those tumor markers, genetic markers we talked about. So of course your treatment goals, yes, you would love for cure. If that's not available, then you would at least like to control the cancer to decrease any replication. Palliation is when only the quality of life is available because the cancer is spread or is in an area that can't be cured or controlled. You can look at this figure on your slides. This just talks about kind of the goals and what you do for cure, control, palliation, kind of this nice algorithm of care. The role of surgery in the cancer. So prevention, removal of non-vital organs to prevent cancer. So for example, Angelina Jolie had a double mastectomy and she had her ovaries removed because of her family genetic history of possible ovarian cancer. So that's part of the prevention. The other parts of the prevention are what we talked about in the previous slide of living a healthy lifestyle, a moderate lifestyle. Then diagnosis and based on the diagnosis, that'll determine the clinical staging, your TNM classification. Now, then the surgery can also help relieve pain if there are areas that are impinging nerves, impinging brain tissue, causing difficulty breathing. The surgery can help with helping those symptoms. Surgery also can cure or control of the cancer. And then you have supportive care with food, suprapubic catheters, colostomies that we'll see in lab. And then you have the rehabilitation stage, which you have reconstructive surgery such as breast implants or the colostomy reversals. Goals of your chemotherapy also cure, control, or palliation. You can read this particular slide. There are certain chemos for certain cancers that can cure. Control, they can also put a patient with breast cancer in remission. There's so many different chemotherapies and research. So this is constantly extending. We are really lucky to live in Houston, where we have so much cancer research going on in our own backyard. All right, so radiation, energy emitted from a source and travels through space or some material, high energy beams. So these are often for areas that maybe are not metastasized in specific local areas to shrink that, to target that particular area. Common side effects of chemo and radiation. This is what you will want to know. So bone marrow suppression. So what's that mean? That means think about what area we're talking about with the blood. That bone marrow suppression, so that would be like a secondary reason for chronic anemia, right? Stomatitis, mucositis, esophagitis. So these are side effects from the ingestion or IV chemotherapy. They do the best they can with chemotherapy, but they are medications. They are drugs that target those cells, those mutated cells, those cells that have differentiated, those neoplasms. However, they can cause damage to surrounding area. Fatigue, the chemo radiation can be very exhausting. Again, these medications are heavy, so there's nausea and vomiting, decreased appetite. It actually changes the way you taste. So you can look at all of these, and these are common side effects. So complications resulting from cancer. So because of bone marrow suppression, because of stomatitis, because of fatigue, because of difficulty eating, because of taste, altered taste sensations, these patients can have malnutrition. They can have third space syndrome. So review these complications in your book for your nursing interventions. Pain assessment and management. So remember, pain is what the patient says it is, right? So this is ongoing. The patient is the primary source of the pain management. Now, drug therapy is used to control pain. For those that have a fear of addiction, there is no research that supports that, and the education, you're just educating the patient that they're taking the medication to target that particular pain. Relaxation therapy, imagery can be used effectively. Those are other supportive measures. Now, the patient and the family needs a lot of psychological support. The emphasis is placed on maintaining optimal quality of life. There's common fears, disfigurement. Imagine you're no longer pooping the way that you used to. Now you're pooping in a colostomy bag, or now you're eating through a tube that's surgically implanted in your abdomen. Or with radiation, brain tumors, breast cancers. Women no longer have hair. So there's a lot of think of your nursing diagnoses for those particular manifestations or those fears. Disruption of relationships. It's a lot. It's psychologically on the family. Financial depletion as well, fear of abandonment, fear of death. So when you're inquiring with patients, you're asking them how they cope with stress in the past. You're looking at what kind of support the patient has. It's very important for the family and the patient to express what is concerning with them. It also, a huge factor of how one copes is the age at the time of diagnosis. And we'll talk more about the pediatric when we do next semester. But look at the older adult considerations. Also past experiences with cancer, the person's attitude, and it also depends on the symptoms. So at a certain point, patients might give up because they're exhausted from the pain, or they might have increased depression because of the recurrence or the body image disruption. So how you can support the patient and the family, being available as you can. If you're inpatient, then you are trying to answer questions with patients, and you're trying that supportive therapy. If you are working in hospice, that's for those of you that don't know, that's the nursing branch that just takes care of the patients who are on palliative care. So they are beyond cure, within 6 months projected death. Always, again, our speaker did say that it is not like her experience with cancer. The provider said she would be dead in 3 years. There are countless examples on providers telling patients timelines, giving them time limits. Your job is to help the patient maintain hope. You are not to take away anyone's hope. You are to assist them in setting realistic goals, long-term and short-term.